Hi, everyone. Thanks for joining us today. Before we get started, just wanted to remind you that this is for attribution, so the deck can be shared and it will be available on our website. This is a 1-hour briefing. The participants will walk you through the deck very quickly, and then we'll move to questions. So I'm just going to introduce everyone. On your left is Matt Anderson, President and CEO of Ontario Health. In the middle is Dr. Vanessa Allen from Public Health Ontario. And on the right is Dr. Dirk Huyer, Ontario's Chief Coroner, as well as the executive lead for our testing approach in Ontario. So I'm just going to turn it over to them now.
Thank you very much. I'll start. My name is Dr. Allen. I think I'm delighted that we have the chance to come speak to you a little bit more about all of the efforts in terms of testing and answer your questions as they come about. I'll just start with some of the reasons for which we do the testing and just to ground the conversation as we go forward in that. The first goal really is to identify individuals who may be infected, both to care for them in their own management, but also to make sure that they have the supports around them to prevent any further transmission. The second goal is really the aggressive management of potential contacts, making sure that those individuals are identified and again have the supports to keep the community safe. And lastly, testing serves a very important role in terms of understanding where COVID is in our communities and in our institutions and providing data for the policies that are underway. I'd like to highlight the different kinds of testing that we use. The mainstay of testing is the swab of the nose, a molecular test we call it, or a PCR. And this is the mainstay of diagnosis and probably what many of you have received. It is a very, very good test, particularly at the time at which you have symptoms. We know that the sensitivity is very high, so it's very unlikely to miss cases. And it's very, very specific. So again, very low risk of false negatives. That being said, it does have a role in asymptomatic testing, but it's not as well understood. And I think what's important there is a negative test by this method, the swab in the nose, when you have no symptoms, says at that point in time you do not have infection, but it does not say that you could be incubating the infection and have it the next day, for example. So it's important to understand that the same precautions need to take place. The second major type of testing is serology, and serology is a blood test, and it measures the antibodies. And we are learning more and more about what the role is, but currently is not a primary test for understanding whether you do or do not have COVID-19. And we also do not know if you have these antibodies, whether that means you're protected or immune. Both of these forms of testing, so the swab in the nose, for example, or the blood test, are available both as lab-based tests and point-of-care tests. The point-of-care tests to date have not performed as well as the tests that are in the lab, but there are a lot of incredible advances, and we hope to be able to leverage that capacity further. So in building a significant amount of capacity, which will be described further, I think it's important to note that in order to achieve these goals of testing, there's 3 primary strategies for how this is delivered. The first one is to test individuals, primarily those that present to assessment centers or their clinicians with symptoms or concerns that they might be infected. And the guidance that has been issued by the Ministry of Health and the Chief Medical Officer of Health really guides how we can search for individuals who are at high risk of infection. The second part of our testing strategy really outlines how we can use testing in understanding outbreaks and contact management. And that is a huge amount of testing, but it waxes and wanes depending on what amount of disease is circulating in the community. And then the last part, which Dr. Huyer will go into in more detail, is these targeted campaigns. So above and beyond the testing that is really guided on individual case management, it's really to be proactive and better understand what's circulating in our community and how that will shape the efforts going forward. With that, I'll pass it over to Matt Anderson.
Great. Thank you, Dr. Allen. Good morning, everyone. Thank you for the opportunity to come and speak with you again this morning. I'm going to talk a little bit about the actual testing network. What some of you may not know is that prior to COVID, our public health labs were not connected to our hospital labs and our commercial labs, meaning that it was very difficult for us to coordinate a large volume of testing and test results. Early on in our response, we've established a network that goes all across the province where people are able to get their tests and do this in a coordinated fashion. We've achieved a number of things over that period of time, over the last number of weeks. We've tested over 660,000 tests. We do have the most testing volumes, or among the most testing volumes in the country. We've built our capacity now. Before our networked lab started, our daily capacity was at around 4,000 tests per day. We're now able to do in the order of magnitude of 20,000 tests per day. Largely, most of you will access this through the assessment centers that Dr. Allen mentioned. Again, a number of months ago when this started, we had no assessment centers. Now we have 131 assessment centers across the province. These 131 assessment centers are connected to approximately 20 labs, a little over 20 labs. And so this is what is the backbone of our testing infrastructure. We do the testing in the lab, and then we share these results through the network to get information back out, both most importantly to the person tested, but also to the public health units and into Public Health Ontario. Just for those of you who have slides, I'm just moving to the next slide, which is entitled Testing Volumes at a Glance. So there's been much discussion around our testing volumes. We today did a little over 18,000 tests. Again, and along the lines of what Dr. Allen said, what we really do is we focus on the goals of testing and try to use our capacity to the maximum to achieve the goals of testing. That does result in some variation on any given day. But right now, we see that we're at a very high peak in terms of our testing volumes. The other chart that is on that slide is our turnaround times. What's very important to us and part of what we're working through, you might imagine that creating a network of 131 assessment centers, a little over 20 labs, a very large geography across the province of Ontario, tapping into over 30 public health units. There's many logistics that we have to work through on a daily basis. Our lab partners have been absolutely phenomenal. They get on a call every morning, working through whatever challenges we may be facing, any logistics, be them supply, moving product back and forth. Tremendous response from a number of partners in our labs all across the province, all to drive towards turnaround times. You'll see our chart at the bottom of that list. Our goals is that at least 80% of the time that our turnaround time is 2 days or less. Depending on our volumes and the things that are going on, we achieve that goal or we fall a little short. We continue to refine our network as we wish to be able to be highly reliable in our turnaround times. One more slide from me with respect to our network. It's just called Testing Volumes at a Glance. You will see that we do monitor our testing relative to our counterparts across the country. This is interesting information for us as we look at how much testing we do. But again, I would go back to the points raised by Dr. Allen in that we stay very focused on the goals of testing and how are we best able to bring the capacity that we've created to those goals of testing. And I will stop there. I'm going to hand it over to Dr. Huyer to speak about where we're going next with applying our testing capacity relative to our goals for testing.
Thank you very much, Mr. Anderson and Dr. Allen. And good afternoon, I think, almost. Well, no, still good morning to everybody. Thanks for letting me be here. It's been a very busy couple of weeks, and I have learned a lot from my two colleagues who I'm working with and here today with, and I thank you all for that opportunity. It's really crucial to recognize that everything with this pandemic evolves on a regular basis, and it's minute to minute, sometimes hour to hour, day by day, week by week. And everything we're doing is informed by what was done before, and we continue to remember and be reminded that we will continue to change and we continue to evolve. So what's happening now with the testing approach is really fundamentally across the system. So it's built to be supported by Ontario Health, Public Health Ontario, assessment centers, public health units, and many others that are working together to really have a good understanding of the pandemic in the best way possible, focusing on the three goals that Dr. Allen started with. And just to remind you of those, it's really to identify anybody with COVID-19 and recognize the spread within the community, aggressively support the contact tracing and the case management that's so excellently done by public health units, and again, fully get more understanding and broader understanding, if we can, for the population and what's ongoing in the community to help to inform the approaches as we move forward. So moving back to slide 10, really, I think I've articulated all of those, but it's really making sure that we're able to have the ability, the opportunity, and the way to identify, contain, and monitor any new cases and spread of COVID-19. There's been expansion of the testing availability to help support public confidence and help to support the efforts and the approaches and the activities to reopen the economy in Ontario, and likely more broadly, we will inform others by the learnings that we have. There's been a number of steps, both from the work that Dr. Allen and Mr. Anderson have talked about, but as well as other work by many different participants, specifically the assessment centers and other people who have been doing testing, the public health units, to ensure that testing is available, accessible, and widespread. And the Ministry of Health has really done a lot to contribute to that. But as I said, and I'm going to reiterate, we need to learn from each testing phase. We learned from the initial steps. We continue to learn now. So we're going to plan, we're going to do the work, we're going to study that work, and then we're going to act and potentially evolve the plans and evolve the approaches to care and management of those with COVID-19, but also to understanding COVID-19 throughout the community. I'm going to move on to the next slide, which is the evolution of the testing plan. And fundamentally, the approach to testing is built on the expertise of those who have knowledge and understanding and have studied or researched or work in the area of infectious disease. And there is a testing strategy expert panel. That testing strategy expert panel provides foundational understanding of what the testing strategy would be from a scientific and an evidence-informed approach. That information is provided to the Ministry of Health and specifically to Dr. David Williams, and he provided direct guidance through his means about what testing should be, and that was changed on May the 14th to broaden from symptomatic testing in priority populations, such as those who have had illness in hospital, those who are working in healthcare, first responders, amongst other priority populations, to broaden it out to all people who have symptoms. And those symptoms are very broad, and essentially if people have symptoms that would be seen in a COVID-19 illness, those people may go get testing, and that will help us to have a better understanding of the symptoms related to COVID and also have a better understanding if people do have COVID-19 or not. Beyond that, there's been other steps that have been taken to broaden the testing availability, and that focuses on asymptomatic people. And I think that the term asymptomatic is often talked about in different ways. Essentially, if I can simplify it for myself, it's really someone who didn't recognize they might have had symptoms that are related to COVID, or someone who doesn't have any symptoms of illness. But if they have concern, then risk-based testing can be facilitated and is available to people who are concerned they may have been exposed to COVID-19 in whatever way they have those concerns. Those are appropriate concerns and individual concerns of that particular person. Secondarily, when people are at risk of exposure, and that risk may be from a variety of different ways. It may be from their intersections that they did on a personal level. It may be intersections that they do during their work, such as people who work regularly intersecting with the public, healthcare workers, their families, others who work in settings such as grocery stores or other public-facing actions. So that's where we're at right now. And that's what we've seen, is we've seen a significant number of other people coming for testing. And we continue to support that and gain a better understanding. It still needs to be sorted through by the experts as to what we've learned this week from the additional testing. And we're not in a position right now to give all of those answers, but certainly very important. The next slide talks about the fundamental important role that the public health units have. They are experts in public health. They are experts in managing and understanding and responding to infectious disease such as COVID-19, and case and contact management is a crucial aspect of that. And as you can see on the slide, for those of you who have it, we have across Ontario all new cases that are brought to the attention through testing or through other means to the public health units. 89%, 89.4, I would round that up to 90% of new cases have been reached within 24 hours. And there is some change. It's difficult to say how quickly a person will attend for assessment and testing. So the timing between actually having the initial contact is sometimes variable, but really what it speaks to is the person develops symptoms or has that worry, they attend to receive testing, and within a prompt time frame, and the laboratory is working diligently to ensure turnaround quickly, as Mr. Anderson talked about. The patient will receive those results, and then the public health unit will also receive those results and reach out to the patient and identify who they might have been in contact with, and those contacts are then reached out to by the staff that are associated with the public health units. So this is fundamental for us to be able to track and to be able to close that environment to reduce the potential of any further spread. So as Dr. Allen talked about, and could go back to the asymptomatic portion of the triangle, what we're doing right now, and informed both by the testing strategy expert panel, but also additional work that's been done and conversations that have occurred more broadly, it's really trying to get an understanding of what may be occurring within the community. And this is what is often described as surveillance testing, but the reality is it's testing at a moment in time to try to understand what might be present within a particular population, a particular setting, or a particular community. And it could be broader than that. So a setting could be a congregate care living. A community could be a small town that's not have so much population as Toronto would be. Toronto would obviously be a community as well. But also, and then there could be a different setting like a workplace, where all of those different settings may have different reasons to be able to have testing completed. And it really is to try to understand at that moment, is there illness present within there, to help to understand more broadly what's in the community, but also is there something in those risk-informed decisions. So the important thing in this is thinking about the purpose and the reason and the methods of doing that testing. And that's the work that's going on right now. There's been a number of areas, and you can see on the testing calendar, number of areas where we've done a lot of work. The long-term care homes, many of you would know, all residents and all staff were tested to understand at that point in time in that facility what was the presence. Because I'll just pause for a minute and remind back to what Dr. Allen said, which a test is a moment in time. So when that test is negative at that moment in time, it doesn't mean that the person is necessarily free of the disease, and they could have been exposed to somebody with COVID and may have gotten the test before the disease has fully developed within the body and therefore available to be identified through testing. So moving back to where I was, the long-term care residents have, and all of the homes were tested, just over about 30% of retirement home testing has been done. We, over the last week, staff at the LCBO were provided the opportunity to seek testing and assessment centers, and a number of staff did present. The Toronto Police and their partner first responders, paramedics, and fire joined together, led by the paramedics completing the swabbing to test first responders, again, in a discrete time-limited approach. Hospital workers across Ontario, in places where hospitals have had outbreaks, are having approaches to testing as well to try to understand, again, the prevalence within the staff at that particular point. About 5 correctional facilities also, both staff and inmates have gone through testing, and all of these things are all being, we make best efforts to understand the results from all of those tests, which will then inform further testing within that particular setting, or also to inform broader understanding within the community and inform really the individuals who might have been tested, obviously, to give them the answers about what their results were that particular day. So I think that speaks fairly broadly about all of the different things that we're doing, and it really is a very active time. We are working together with many within the ministries, many within different populations and settings, many within industry and business, to help to think about how are we going to do this over the next number of weeks as we continue to move to a reopened economy and a reopened Ontario. So thank you very much for the opportunity to present. I think I'm going to turn to my colleagues to see if you have anything else to add, or otherwise we'll open for questions.
I'm good, thank you. Thank you, Dirk, and probably over to Haley.
Okay, we're going to open for questions. Just a reminder, 1 question, 1 follow-up. And if the operator can just remind people how to get in the question queue, that would be great.
Ladies and gentlemen, if you do have any questions, please press star 1. If you're using a speakerphone, please lift your handset before pressing any keys.
Okay, we're going to move to questions now. Just a reminder, 1 question, 1 follow-up.
Your first question comes from Lucas Meyer with News Talk 1010. Please go ahead.
Hi, everyone. Thank you for taking our question. So I just want to get an idea of what this is actually going to look like on the ground. So, for example, next week it says community-based testing in high COVID active communities. So can you just paint us a picture? What is that going to look like? If you're in one of these communities, is this going to be random testing? Is it going to be, signs with, hey, go get tested? I'm just for people who are seeing this and they want to know, well, what exactly is this going to look like? What is it going to look like? But give us just some real on-the-ground examples of what community-based testing in high COVID active communities means.
Thank you very much for drawing that to the attention. It's a point that I missed, so thank you for that. That's very helpful. So it's Dirk Huyer, and what it's going to look like is going to be variable to the particular community and going to be variable to the particular area. But we are working closely with Toronto Public Health as well as Peel Public Health, and what we're going to do is develop a response that works most effectively for what is where the concerns are. So if the concern is in say a place of business where there may be some increased concern about COVID activity, we're going to work together to bring a team to the facility to do the swabbing within the facility. And so the workers, the staff, the employees would have the opportunity to be tested. Well, we would be testing that workforce to try to understand exactly what's going on, to look to see what the spread is. So we will have mobile teams. The other opportunity will be in people attending assessment centers, and it's going to be a specific case-by-case determination. If the setting is mobile, so in other words, people work variable times and variable hours, it may be that the assessment center is the approach that's taken for the testing opportunity, or if the setting is not able to be mobile, then we will work to bring a mobile team to the facility to ensure that those who live or work in that facility are all provided the opportunity and testing will be completed. So it really is something like a van or a bus coming, work together in a collaborative way with contribution from the workplace or the setting and involvement of the public health unit to do that testing and provide an understanding of what's happening.
Thank you. And can I go, Haley? Am I good?
Yes, go ahead.
Hello?
Yes, go ahead.
Oh, sorry. Thanks, Haley. And so my follow-up is for slide 14, if we could just look past, obviously, the long-term care homes or retirement homes for a second, but that gray section there, all of those different sectors, you've got everything from, the supply chain, sports, research, and then in the general population sectors, municipal affairs, the chemo and cancer patients, there's just so many people who fit into these categories. So I'm just trying to figure out, for those gray sections, is testing for those populations going as well to start by a particular date? Does that include next week? It's just those are all kind of separated. So for those gray areas, when exactly is that starting?
Yeah, all of that will be determined through a planning with those individual areas. The gray is not starting next week. The areas in the blue are the areas that we are focused on right now and developing. Some are developing plans. We're actively doing testing. So for example, in retirement homes, we're actively doing testing. Long-term care homes, we're working to test staff again after the initial testing that was done. Congregate care setting, there's an action plan that's being that is being finalized as far as additional testing. A number of those settings have already had testing, and we're moving out further into correctional facilities over the next period of time. So all of the gray areas are areas that we will be working together with the sectors and the ministries to determine what will be the most effective and the best purpose-driven testing to have a good understanding, and then we will develop plans and schedule those, because if they don't have symptoms and if there isn't a concern of an outbreak, which are the priority areas that we must be focusing upon, these are testing on a discrete, time-limited, or a time-specific period of time that will be informed by working together with those who are in those different areas to help to ensure that we're getting the best understanding.
It's Matt Anderson speaking. If I can just add one comment to Dr. Huyer's comment. I want to make sure that you also understand that it's not like it comes to an end. Dr. Huyer spoke about the idea of learning and the PDSA, or the Plan, Do, Study, Act cycle. We do that with every one of these groups. So a week from now, this plan may look different. Some of these groups have moved up into the blue. Some of the people who are in blue are now done, and new may come into the gray. We're constantly learning and looking at where do we go from here with our lab testing. And just to quickly note, just as an example, when this slide was put together, the chemo cancer patients and dialysis patients were in gray. Our wonderful team up at Humber Regional have already begun doing that testing, and we're now working with others to go after that. So it's a very dynamic. This is a point in time.
Next question.
Your next question comes from Jeff Gray with the Globe and Mail. Please go ahead.
Hi, everybody. My question has to do with lab capacity. So with all this new testing, is it envisaged that we were going to go above the current capacity, expand capacity to test even more than the whatever we're at now, 20,000 a day that I think that we can do? Is that part of the plan?
It's Matt Anderson speaking. I'll answer that first. I'm going to talk about the capacity of the network as we know it, and then I'll hand to Dr. Allen to add on. She speaks about the other modalities that might, in fact, augment the capacity. So the short answer to your question is yes. We are looking at how do we continue to increase capacity. And that's done through a number of ways, looking at there's a number of labs that are already out there and are willing to work with us to become part of the networked group. We also can grow a little bit within there. As you might appreciate, for something like this, there's a number of different concerns as we think about how do we grow our capacity. We have to look at what our supply chain is and how we will make sure we've got enough supplies, those sorts of things. So there's constraints, but we do look to see how can we continue to grow our capacity. This has been a great advantage for Ontario. Obviously, everything that's gone on with COVID-19 is difficult and tragic. However, there are a few really positive things that have come out. They are very small silver linings to a dark cloud, but this idea of a networked lab system all across the province is something that we intend to grow and become a permanent feature of the landscape here in health system in Ontario. Maybe now I'll hand to Dr. Allen to make a few comments about how else we might be able to increase capacity.
Thanks very much, Mr. Anderson. I think the other element to add is we are also planning for the future. So we know in the fall, for example, that there's going to be increased respiratory illness, that there will be, as there's more movement, there are likely to be need for greater testing, and it's really building in that surge capacity. I also really want to speak to the laboratory staff who are putting in incredible efforts to deliver all of this testing. This is really an unparalleled amount of testing in any jurisdiction, but including in Ontario. The other elements that I spoke about a little bit earlier, but just to expand on it, is as serology becomes more available, and there's work currently underway to be able to deliver it, it gives us another opportunity to understand where there is disease in the community that's not picked up by the current PCR programs. So I think it's really thinking about how do we leverage as many tools as possible for individuals to get the results, and also for us to understand at a population level how best to adapt as we move forward. So I think building on what Mr. Anderson said before is really ensuring that we're thinking 6 months out, and how do we make sure that we sustain this as we go forward and it's adaptive. Thank you.
Follow up?
Do you think we need to shoot for 30,000 tests, 40,000 tests? Is that the kind of thing you're looking at, or is there a way you can quantify that?
I think I need you to repeat the question. I'm sorry, I couldn't hear it.
Hello?
I can hear you now.
Hi, sorry.
There we go.
Oh, just ask if there's a number we could put on that a target for future testing to be even more than the 20,000.
Yeah, we have not, wait for the camera to come over. I'm happy to respond to that. We have not set a specific number or target to it. As we think about, and just picking up on Dr. Allen's last point, right now we're modeling out what might this look like, particularly when we get into the fall with multiple different types of respiratory disease. What is the capacity that we could bring forward? And we're testing those hypotheses now.
Next question.
Your next question comes from Allison Jones with the Canadian Press. Please go ahead.
Hi, I just wanted to follow up on Lucas's question. In response to his question about the line on community-based testing, you talked a lot about workplaces that maybe were undergoing outbreaks. Is there a plan beyond targeting specific workplaces? Are we going to see any sort of mobile, truly community-based testing like Windsor has been doing, for example?
Yes, is the answer. And the different public health units are already taking those initiatives. Toronto Public Health has taken initiatives, and there are others as well. Peel has been thinking that way. York has been doing work in a similar way. And what we're doing from a broader perspective is providing additional support to the public health units and to those where there are needs for testing teams. I want to keep the words carefully. Capacity would be what the lab provides. The team would be doing the swabbing to prepare for the testing that would occur in the laboratory. And so, yes, we are working together and developing an approach. We're soon into it, and we're really trying to determine what's going to be the most reliable, sustainable, and scalable approach across the province. And we're literally into it this week running. And the bus was an example of going out to a community and having a structured approach that will make this testing accessible, will make this testing available, and make this testing done in a way that will allow us to understand what we learned from that particular setting. And it could be a number of different settings. A community where there's been identified as an increased number of people with positivity. So it wouldn't be specifically an outbreak, but it would be helping to understand that community more in a greater detailed way. And we would use various ways to invite or offer or provide the opportunity for people to attend. And those are all things that we're actively thinking through on how we are going to ensure that we effectively sample, and sample is a terrible term to use for people, but how we draw the appropriate number to fully understand what may be occurring in that community.
Follow up?
And did I hear Dr. Allen say that serology testing is at least available in some sort of small way at the moment? Are you able to clarify that? Is that something people can go out and get already?
Thank you very much for the question. So there are 2 kits that are currently approved by Health Canada, and they are being evaluated both provincially and nationally to make sure that they perform well. Serology is, as I described before, it doesn't measure the virus itself, it measures antibodies. And one of the concerns with that is if you test too soon, it will be negative, even for a person that's infected. And even if you're positive right now, based on the population prevalence and the nature of these tests, there's a high probability that it'll be a false positive, as high as 50%. So flipping a coin. As we get higher burden of disease and understand this test better, it may become a more helpful tool. The other important note there is we also don't understand whether if you have the antibodies that you will be protected. So the immunity passport is currently not something that's understood or recommended, but we will learn more over the coming months. Where it is being used is there is testing at a population level to understand what the burden of disease is, and many other jurisdictions are doing that as well. So are we missing any centers of infection that then would guide some of the efforts that Dr. Huyer described? So that's the primary focus for where serology has a helpful role as we speak. So the short answer is to your question is it ready for prime time for an individual basis? I would say no, but we are studying it very aggressively to make sure that we understand where it could add value.
Next question.
Your next question comes from Cynthia Mulligan with City TV. Please go ahead.
Hi there, good afternoon. I believe I heard you say that LCBO employees went for testing and a number of them tested positive. I was wondering if you could give us more details, like how many and what percentage? And is the goal to keep track of workers by job, like grocery store workers, for example, must have a much higher exposure rate than many other industries?
So first and foremost, I did not say that, and I apologize if that communication came across. If I did, it was not factual. We don't have any information to suggest that LCBO workers were tested and came back positive. So just first and foremost, that is not something that is factual to my knowledge. So moving from that, though, understanding who is being tested, the answer is yes. We are working together in our strategy to support this surveillance testing to ensure that we do our best to understand the particular sectors, the particular settings, the particular communities that may be tested. So we would, for example, in correctional services where the testing was done, we developed a special reference number for each of the centers to allow an understanding, not at the individual level necessarily to protect the privacy of those who are tested, but from a broader numbers and an aggregate point of view to understand any potential positivity within that particular community. So yes, the different sectors and the different settings and the different populations, it is our plan to be able to identify those, to analyze, to inform. And as Mr. Anderson said, looking at the slide that was brought to the attention of slide 14, where the blue, some may remain in blue as we continue ongoing testing in those sections, but some may move out of the blue because there may not be additional benefit for those particular settings to be tested, and then some will move from the gray in. And so it will really be informed by what we learn as we test.
Follow up?
Okay, thank you. And I apologize. I'm sure I misheard you. My apologies. My second question is more of a follow-up on what Jeff Gray from the Globe and Mail was asking you. When I look at the slide of how many areas you want to test in, surely that you're going to need to expand it greatly above 20,000, like a day. So are we looking at double, triple? Like, what would the ballpark be to have to test this many people?
Sure. Hi there. It's Matt Anderson just responding. Yes, as per the previous comment, we will continue to expand our testing capacity, and picking up again on what Dr. Allen said, as other modalities become available to us, that also gives us more capacity. When we think about the numbers that are put in front of us here, so first off is 20,000 a day. We actually target somewhere a little lower than that, as that brings in quite a bit onto our network, and we want to make sure we maintain our turnaround times. But we do look to expand. Again, we haven't set a specific target yet because we do know the numbers are significant. And we are looking most primarily at the fall to repeat a little bit of what Dr. Allen said, where we would see the potential confluence of flu and other respiratory disease that we'll also have to measure. So it is something we're very conscious of. We schedule as carefully as we can. You do see in our numbers, sometimes the numbers go down, sometimes they go up. A lot of that has to do with the use of our assessment centers, because we want to make sure that we are able to support our assessment centers, but also as we go through and try to schedule all the different groups that we would like to get to. Not all of them, by the way, and going back to one of the points that Dr. Huyer made, not all of them represent that we would necessarily test all in a setting. We may test a group within a setting to get a better understanding of that as well. So there's different strategies we can do to try to manage that while still aggressively testing.
Next question.
Your next question comes from Christina Tenalia with CP24. Please go ahead.
Hi, thank you so much. Wondering if you could talk a little bit about testing in schools for teachers, testing for daycare workers, and also the potential for students and kids who attend daycare, how that process will work and what it'll look like, if anything. I'm just making my way through the slide here.
Hi, Christina. Long time no chat.
Yes.
So thank you for that question. Absolutely. This is something we have not determined yet, but is, again, a live conversation and something that we are focusing upon. Clearly an important issue. Both currently, there was testing of all the current staff in the child care centers that are open for essential workers. And those results are just finishing right now. I don't have the answer for those, but any positive tests would have come to the attention of the public health units. And I'm not aware of an additional outbreak, but there may have been. There was one, as you know, early on, but there hasn't been any since that time that I'm aware of. I may be wrong on that, but that's an example of where testing was done early, and then we're going to work together. There's been initial early conversation, but not sorting through the plan, but that clearly is an area that will be important, not just from a school perspective, but understanding across children, because children have not been as significantly affected percentage-wise as far as we know. There have been some different presentations in children that the healthcare world are learning about, but we will also be working together to better understand what is present within the community of children. So not just schooling, but also children, and then of course the teachers and other staff that would work in a school setting, important for many reasons. So absolutely areas that are on our list, and early conversations, or very early conversations have occurred.
Follow up?
Okay, thank you. Thank you so much, Dr. Huyer. Also, when I take a look at the list here, slide page 14, and I know Lucas already asked the question about the blue parts and then the gray parts. Can I follow up? And I apologize if I missed this. I've been listening here, but going through the slides. Where does the gray area really fit in terms of a timeline? I know you said the parts in blue are the priority, but can you perhaps take us a bit through the next few weeks as to how this will look? I know the Premier previously said, truck drivers, cab drivers, those are the groups he would like to see tested. But when we take a look at the list here, transport services, for example, is in the gray area.
Great. It's Matt Anderson. I'm going to attempt to answer that for you. And so in the gray area are the groups that we are talking with now. What we've committed to amongst ourselves and back to the ministry and the government is that we ultimately wish to build a 4-week rolling calendar. What you're seeing is a 2-week. We want to get to a 4-week rolling calendar so everybody can see the priorities in what order we are bringing things on. So that's how we'll do our scheduling. It'll allow various groups to be prepared. It allows us to get as Dr. Huyer described, we have to get our testing teams. Oftentimes we have to get testing teams in place. Many times we'll in fact direct people to our assessment centers. So there's different strategies that we'll be employing to move forward. many of the folks that are in the gray, as I mentioned, there's a couple of areas there that are already being brought into our testing right now. And another factor that plays into it is just the logistics around that testing. And so when we think about transportation, as for instance, which the Premier has made very clear is one of our priority areas, so we are working with MTO and others to work through the logistics. That group being a very, very mobile group, we're working through how might we be able to support that group. Would they go to assessment centers? Will we set up something in certain areas? And the other thing that I just, on this point, is part of that discussion as well. It goes back to the very first slide that Dr. Allen put forward, and I think, the most important slide in the deck in our discussions today of what is our purpose? And is our purpose first and foremost always is about safety, and safety of the individuals, safety of the population. So how does that sort of play out? Because going to assessment centers, it is unlikely that we would be measuring, for instance, a specific community beyond that assessment center. If we want to get an understanding of long-term care, as for instance, then we work specifically with the long-term care sector to get an understanding of that sector. So depending on what the goals are, also determines what the logistics might be and how fast or how far out we need to plan that grouping in order to get it on the schedule and move it forward.
Next question.
Your next question comes from Victoria Gibson with iPolitics. Please go ahead.
Hi, everyone. I want to ask just a little bit more about serological testing. You're saying that it's being used at a population level right now to understand the burden of disease. I'm wondering if that includes any particular areas in Ontario, and if you can let us know where.
Thank you very much for the question. There are several studies that I'm aware of. One is through Canadian Blood Service and Quebec. And so they are actually using blood donations as a way to do seroprevalence. So that is underway, and I believe it's over 40,000 specimens to be done in relatively short order, I believe in months at the latest. And that is a standard method for when a new pathogen emerges to better understand what the prevalence is. Concurrently, there's several efforts. There's an effort to look at seroprevalence among healthcare workers that's led by some of our colleagues at the Hospital for Sick Children. There's also a study going on at Public Health Ontario to understand, represent it basically with a sampling that's geographically and demographically distributed that includes April and May samples that should be available again within a month. So I think that will give us some very important information. There's other jurisdictions that have done those studies, and interestingly enough, even in settings where they had relatively high burden, such as New York City, the population prevalence is less than 20%, and so nowhere close to what would amount to herd immunity. And so it's understanding how the seroprevalence evolves over time. So the other component of the studies that are being planned locally in Ontario are this sequential analysis of what the seroprevalence is, so that it can help to guide what the policies are as we go forward. The other example, just of note, is there's a national initiative called the Immunity Task Force, which we're all collaborating on to better understand how these tests perform and how we can understand this at a national level and contribute to those efforts. So I think there'll be a lot more to come in the coming weeks to month, but it's really an adjunct to all of the other great work that everyone is doing.
Just before we move to the follow-up question, Victoria, just a reminder, if anybody wants to join the question queue who hasn't asked a question yet and who is from an outlet that hasn't had a chance to ask a question, to please move in the queue now. Okay, Victoria, follow up.
Thanks, Haley. I just want to follow up a little bit more on, you're saying the Public Health Ontario study is sampling across geographies and demographics. How exactly is that being done? Like, where are these blood samples coming from? Are these ones that were taken for other healthcare diagnostic reasons, or what exactly is the sample that you're working with here?
Yes, so the samples haven't been tested yet, but the strategy, and it's going through consultation with the community, is to use pre-existing samples because there is already a lot of testing that is performed, and with the statistical caveats, you can still understand burden of disease in different communities and better inform what that variability is, and where we might target more efforts, or those that are targeting the efforts might use this data to better better inform what the next strategies are.
Okay, last question.
Your final question comes from David Haynes with Queen's Park Briefing. Please go ahead. David, your line is open. You may have us on mute.
Pardon me, I did. You mentioned earlier kind of testing out the kind of hypothesis for how to scale up testing by fall. What currently are the limits and obstacles to scaling up that testing?
It's Matt Anderson. I'll start, and then I'll hand to Dr. Allen on any of the things that that I miss. I would say there's at least 4 different things that we consider, and Dr. Allen may tell me about the 5th and the 6th that I've forgotten. Any combination of we need lab capacity. That's actually one of our easier ones to address, but we look at lab capacity. And this is all starting with using the current modality that we're talking about. So I'm going to leave out, because we've discussed earlier, the different modalities. So sticking with our current modality, we look at our labs and how much lab capacity is there, and can we grow that. Supply will be another key one. There's the swabs that you've heard us talk about before, but there's many other elements of supply and supply chain. The supply chain in lab medicine is much like it is in other areas where it's a global supply chain, can be a little bit difficult to source. So we're looking at different alternatives there, including domestic supply chain to try to hold back on any of those challenges. We also look at logistics of just how are we moving all this? Do we have a logistical infrastructure that we can move supply and the swabs, et cetera, back and forth? And the 4th one that I'll mention, and then I'll hand it over to Dr. Allen, is human resources. We have an amazing group of lab technicians who have been absolutely phenomenal in stepping up to support us here. We're doing volumes and intensity that we haven't done before in the province of Ontario for an extended period. As we think about increasing that, whether we consider doubling it or tripling it, all along the way, we need to make sure that at least these elements need to be accounted for as we think about how we can bring that online, all with the understanding that these are solvable problems, but we have to work our way through and make sure we're bringing online sort of simultaneously against these elements in order for us to be successful. Dr. Allen, was there anything you'd like to add?
I think that's fantastic. The other thing I just want to add is a reiteration of what you said before, which is really also the integration of the labs to make sure that we work at maximal capacity and work as a whole. And that's been one of the benefits of what's been created through this effort. So thank you.
Follow up?
I know it's a couple months away for Health Canada to give a thumbs up to serological testing and so on. Do you have an idea of how much capacity of how many tests might be performed on a daily basis from that? Although it wouldn't be a diagnosis of who has the virus at a given point.
That's a great question. I don't think capacity in and of itself is as much of an issue with serology as it is with molecular test. It's a much easier test to process. But I think, I don't think it's the capacity overall. We are looking at how do we plan for current needs for capacity as well as future needs, expecting that we will learn more in the next several months. I think the larger issue is just how do we make sure that if it is offered, that it's supportive of individual decision-making and public health decision-making. And so I think that's really the crux of how we ensure that whatever capacity we develop is used to those ends. And, the worst thing that I can imagine is we tell somebody, for example, that they haven't had COVID, and in fact they have, and that's an important item in their decision-making and in public health follow-up. So I would say capacity is not an issue, but there are other issues that I think really need to be thought through together. Thank you.
Okay, there's one more reporter on the line, so we'll move to the last question.
Your final question comes from Megan Fitzpatrick with CBC News. Please go ahead.
Hi, can you hear me?
Yes.
Yes.
Okay, great. I just want to make sure I'm understanding you right in terms of basically who is getting tested and who can get tested in Ontario right now. maybe if you could just comment, it's not a total free-for-all right now, correct? It's not as though anyone who wants a test can get one. The guidelines are still only if you have one symptom at least, or if you're asymptomatic and concerned you've been exposed. And then sort of the second prong is this targeted testing, this proactive testing that you're doing with these targeted groups. Is that correct?
So I'll take that. It's Dirk Huyer. So yes, that's correct. And but if people are attending at assessment centers, then they are attending because they have concerns. And so they're attending because they have a concern of being exposed in some way, or they're concerned that they have something. The guidance that Dr. Williams provided and that the Ministry of Health has released is that anyone with symptoms across Ontario can present for testing. And then the other the other three areas are risk informed. And that's when somebody is concerned they've been exposed, or they may be in a position based upon their employment that they may have exposure to COVID. And then within that would be, if people are worried that they have COVID, then they're presenting, then they would be assessed and would be provided that test. The other area, which is what we've talked about a lot, is the area of specific populations. Those are going to be scheduled, and those ones are not with symptoms, but there's a reason for doing that testing, and those reasons would be purpose-driven, as Mr. Anderson talked about before, to help to understand that particular setting, that particular population, that particular community, and to help to ensure that we have a good recognition of any risk that may be present. Did you want to add anything to Mr. Anderson?
I think Dr. Huyer, you got it. I would just reiterate the point on what's not happening is the assessment centers are not judging your judgment on if you were at risk. If you feel that you have been at risk and feel that you need that test gets done.
And then just, if I can do one quick follow-up just to end off with that, I think the important thing that we need to remember again, and I know we've said it, we've all said it a number of times, but I really want to reiterate that it's important that people, when they have that test, that's the point in time. So that's that moment of the day, or the moment of the week, or the hour or the minute when that test was done, that test is negative. It doesn't mean that they didn't necessarily have it. And so caution, proper care such as hand hygiene, physical distancing, maintaining all of the prevention practices are fundamental and fundamentally important to ensure that we continue to battle COVID-19, battle the potential of any spread, and protect each other through the work that we're doing together. Everybody is in this together, and everybody needs to work together to ensure that we are taking all the necessary steps to protect each other and ourselves.
Megan, if you'd like one follow-up, you can have.
Okay, thank you. Just wondering then, if with more testing being done, should we expect to see more positive results? I mean, is it possible that just if you're testing more widely in the community, we might see the case numbers go up? And then what might that mean in terms of reopening the economy? You were talking about how these testing strategies can underpin policy decisions. So can you speak to that at all in terms of what we might see in terms of case numbers by testing way more people?
The three of us are looking at each other. We're deciding. We all know a similar answer.
Yeah.
And let's all three of us go with this one.
Sure.
So I'm going to start off and say,
That sounds good.
Absolutely. This is information we want to know, and this is information that we'll learn from this testing. I don't have the answers, and then there's a couple steps beyond, which you've got to the policy and the reopening on those. But the testing that we're doing will give us an understanding of the disease and a better understanding of the disease. So that's going to be my part. And then I don't know if Dr. Allen or Mr. Anderson's going to go next.
Okay. Sorry, folks on the camera, we're making you work hard today. The only thing that I would add, and directly to your question, it stands to reason that if we're doing more testing, we may find more cases. But again, going back to the points that have been raised throughout the session here is, where are those cases? Did this create, are we seeing a new outbreak? Are we seeing something different than what we saw before? Are we confirming what we saw before? Again, going through the priorities, number one is making sure everyone is safe. and helping to ensure that. And if there is somebody out there who is symptomatic and sick, or somebody who believes they've been exposed and may be ill or may be at risk, we want to help them. That's priority number one. Through here, if we identify more cases, if those cases are in centers or areas where we already are, where we've talked already about the public health units who are moving out, doing all kinds of different testing, then fine, that's confirming that area. Perhaps we will find something that we didn't know about, and there will be some cases raised somewhere else in the province that we were unaware of. We'll see if that happens, and if it does, we'll adjust. So again, we look at the safety, the numbers, and how do we ensure that we're supporting our population and understanding this disease.
Okay, thanks everyone. And just an update, the Premier's press conference will now start at 1:15. Thanks everyone.
Thank you, everybody.